Good morning, everyone. My name is Andrea Gill, and I'm one of the senior pharmacists at Alder Hey Children's Hospital in Liverpool. And it's a real joy to be able to speak to you today. Thank you very much for the invitation to join what looks to be a very interesting conference. So, as I mentioned, I work in Alder Hey Children's Hospital in Liverpool in the United Kingdom. Alder Hey is situated in the northwest of England, is approximately 3 hours drive from London. The hospital itself is a specialist children's hospital, and it provides primary care for children in the community, secondary care for children in hospital, and tertiary care, which is referred in from both our own community and from elsewhere in the north of England. Annually, we see over 2,700 children, and we have approximately 250 beds. Of those 250, approximately 550 are for critical care patients. And I know from speaking to colleagues in your hospital, in the National Children's Hospital in Vietnam, we're a much smaller hospital than you are, but I hopefully you will still have something to share that will be of interest to you today. So our new hospital opened in 2015, so we've been in it almost 7 years. And at the time, it was quite innovative. We've got state-of-the-art technology and facilities, and the design of the hospital was done alongside children to try and make it as least scary and most inviting place to come to. And as you can see there, it's you can't actually see the wards from the main foyer of the hospital. And children really enjoy coming to our hospital. This is the intensive care unit, and this was prior to us opening, so there are no patients here. But we have 24 beds on the intensive care unit, and you can see some of our staff here. But what I'm planning to talk to you about today is to talk about clinical pharmacy on intensive care in the United Kingdom, some of the roles that are undertaken by PICU and NICU pharmacists, and then to illustrate that by what we actually do on a day-to-day basis. So, but at this point, I would like to introduce you to the NPPG, which is an organisation which is very active for paediatric pharmacists and neonatal pharmacists in the UK. It's a charity and has about approximately 500 members. So the vision of the organisation is to enable all pharmacy professionals to deliver outstanding care for the benefit of neonates, children and young people. And the mission is that this vision will be achieved by advancing the education and training of pharmacy professionals so that they can deliver outstanding patient care, by championing quality research, and by leading the national paediatric medicines agenda. And so as part of leading the national agenda for paediatric medicines, the NPPG are very active in producing documents such as the one I'm going to share with you. And very much these are recognised nationally and also prevent each individual hospital doing things separately and very much duplicating work. So the document that I'm going to talk to you through is this one. So it's called Clinical Staffing Standards in Paediatric Critical Care. And it is to be used to advise on how pharmacy services should support intensive care units across the UK. So it starts off by very much assuming that every critical care unit will have senior clinical pharmacists as part of the staff. So you can see highlighted in blue here, clinical pharmacists are essential practitioners within the critical care multidisciplinary team and are vital to the routine delivery of medicines optimization in critical care. And that is the case in all of our critical care units in the UK. There would be a senior pharmacist appointed. But in terms of how many senior pharmacists you need to have, the staffing standards could go on to talk about this. So they say the paediatric critical care pharmacists must have sufficient time allocated to fulfil their specialist role, and this should be a minimum of 0.024 whole-time equivalent pharmacist per day for each funded level 3 bed, so they're the highest acuity patients, and 0.024 for every 2 funded level 2 beds, so they're more like a high dependency type beds. So for Alder Hey, this would work out to be 5 whole-time equivalents. We only have 3 whole-time equivalents working on our intensive care unit. So these standards are not mandatory, but they are guidance. And certainly we're using them to try and persuade the hospital to increase the number of pharmacists who are working on our critical care unit. The other document which is important to consider at this point is the Advanced Pharmacy Practice Competency Framework that's been developed by the Royal Pharmaceutical Society of the UK. This document goes through the level of competence that senior pharmacists should have if they would be classed themselves as advanced practitioners. And it separates these competencies into advanced stage 1, advanced stage 2, and then mastery, which is really the expert clinical practitioner, the highest level of clinical practice that somebody can attain to. And so this and the neonatal and paediatric care expert professional practice curriculum are really important documents to refer to when we're looking at the standard of care that we should be working to on our paediatric intensive care unit. So the qualifications and competencies in the standard document says that specialist pharmacists practicing in paediatric critical care must be able to demonstrate competency at least to the advanced stage 2 level, but they should be progressing towards mastery, so the highest level of clinical care. Day-to-day clinical cover can be provided by those at a lower stage, so advanced stage 1, but that should be with appropriate support from a more senior specialist. So in our hospital, we have 2 specialist PICU pharmacists. So they have got a Master of Pharmacy as their basic degree. They've done a 2-year postgraduate clinical pharmacy diploma, which allows them to specialise in hospital pharmacy. And then they have to have at least 5 years experience working in a relevant clinical role within a hospital pharmacy team. We have 1 supporting pharmacist who again has a Master of Pharmacy, a postgraduate clinical diploma, but she only needs to have 2 years clinical experience. Now, all of our team have got a lot more experience than this, but these are the minimum qualifications that would be required to work on the PICU team. We also have a pharmacy technician who visits the ward twice a week, and that is very much to ensure stock control is appropriately managed. So what roles are these staff undertaking then? Well, again, within the NPPG standards document, it goes through the list of what they're expecting clinical pharmacists to do. So the first one would be to develop and maintain medication-related guidance. So the pharmacist's main responsibility would be the person with the main responsibility for some of these guidelines, such as the antibiotic guidelines or the IV therapy guidelines. But as well as that, they should also be involved in the review of all clinical guidelines that mention medication. So there may be a resuscitation guideline, for instance, which would be written by medical or nursing colleagues, but the pharmacist would be expected to make sure that all the medicines related information within that guideline was accurate and safe. The pharmacists are also involved in education and training of members of the critical care multidisciplinary team and the pharmacy department as well when it comes to aspects of critical care medication. They're involved in contingency planning for drug shortages. So if we know that there's likely to be a drug shortage, they would work with the relevant people to review whether suitable alternatives were available and whether new guidance was required to support that. They're also involved in the introduction of new medicinal products to the unit. So they will be part of the formulary request, which goes to our Drug and Therapeutics Committee. That will provide the evidence and supporting literature to determine why there is a need for this new drug to be introduced. The pharmacist will provide advice on high cost, high risk and restricted medications, such as antibiotics, which could only be used in particular scenarios. They will advise and coordinate parenteral nutrition, look at how costs can be reduced, undertake quality improvement and audit. They'll review medication errors that happen on the unit, and I'll discuss that a little bit later on, but they'll attend governance meetings and provide advice on how we can reduce the frequency of medication errors, including attendance at relevant meetings, as mentioned. On our unit, and a majority of the others in the UK as well, the specialist pharmacists are qualified as independent prescribers, which means that they can prescribe themselves within their area of competence any drugs, depending on the role that they're undertaking. In our units, the most frequent areas where the pharmacist would prescribe would be when a new patient is admitted, if medication that they're regularly undertaking has been missed off, when they're changing doses of medication based on therapeutic drug monitoring, so increasing or reducing a vancomycin level, for instance, or when they're optimizing sedation and analgesia for the patient as well. They will provide day-to-day support for transport teams. They will also support some of the technologies that are used to support safer prescribing and administration, such as smart pump infusion, smart infusion pump drug libraries, and the electronic prescribing and medicines administration system that are used. And within the standard documents as well, they state that there should be time allocated for the clinical pharmacist to carry out research. So that's the PICU standards. So we have a very similar document for neonatal intensive care units, and that's available on this particular link. And it's similar, the information in there, going through what a neonatal pharmacist should be undertaking, and the number of pharmacists that should be allocated depending on the acuity of the beds that are in the particular hospital themselves. The NPPG also facilitates two specialist interest groups, so the paediatric critical care and the neonatal intensive care unit specialist interest groups. So these allow all the pharmacists who are working within paediatric or neonatal critical care to contact each other. So there are very lively discussion forums available. Often on a Friday afternoon, we will get messages through from colleagues in another hospital saying, we've got a very unusual patient, we've never used this drug before, has anybody got any information on how it's best used, or how it may be an oral medication may be crushed to give down a nasogastric tube, or whatever. So it's really good to be able to connect with colleagues and share that type of information. They also run study days. They produce various frameworks or documents such as that linked with standard concentrations for IV infusions. And both the Paediatric Critical Care Unit Specialist Interest Group will link with the Paediatric Intensive Care Society, which is the parallel group for medical and nursing staff. And the NICU Specialist Interest Group will link with BAPM, which is the British Association for Perinatal Medicine, again, where colleagues from the medical and nursing fraternity would be. And so these are very useful groups to be part of and support us a lot. So they're the roles that should be undertaken and the standard staff, etc. What about how this is actually put into practice? So I thought it would be worth going through a day in the life of one of our PICU pharmacists. So the day usually starts at around 9 o'clock. And at that point, the pharmacist will review the overnight handover that's been produced by the medical staff who were working on the unit overnight. So by looking at this information, they will identify which patients they should prioritise for pharmaceutical review. At this point too, it will require a remote check of the electronic patient records, where they'll be able to have a look at the medical plan for the patient in more detail. They can look at blood results, both electrolytes, full blood count, and also any therapeutic drug monitoring results that may be available. And they'll also look at the electronic fluid balance as well, to determine whether any changes are required to their infusion medicines and so on. Once I've done that, about 10 o'clock, they will then attend the ward. And at this point, they will review the patients in order of priority. For any new patients, they would be seen as priority patients straight away. And the pharmacist will initially do a medicines reconciliation. So this is the process by which they would discuss with the parents if they're available, or they will access the community care colleague information to see what the regular medicines are that this patient should be taking. At that point, they will make sure that they've been prescribed, and if they haven't, they will discuss that with the relevant specialties to determine whether they need to be considered to be continued. And they'll also think about whether those medicines are still appropriate depending on the patient's new clinical situation and organ function, etc. Once they've undertaken the medicines reconciliation, they will then check the rest of the prescription. And they'll look at that in terms of accuracy. So have things been prescribed correctly? Is it the right time, the right dose, the right route of administration, etc. But also thinking about whether there are any problems with drug interactions with new medicines that have been prescribed, any adverse drug reactions that the patient is actually experiencing at the moment, which will require a change of drug therapy. Pharmacists will also review the continuous infusions for the patients, and that will be reviewing the pumps to make sure the rates are running correctly, looking at the compatibilities of the medicines that may be running together through an IV line, and assessing whether drugs are appropriate to be given by a peripheral or central administration. As I've also mentioned, they'll look at the choice of medication. So are antibiotics appropriate for the bacteria that may be growing for the patient? Do drugs need to be increased in doses if the patient's not responding? Are any adjuvant medications required if the patient is it's to prevent adverse drug reactions, etc. Pharmacists will also assess the sedation and analgesia requirements of the patient and advise on a weaning plan if the ventilation and other requirements are reducing and the patient's improving. If they do identify any medication errors as part of this review, those will be recorded on a database. So they do that at the end of each of their ward rounds, and then the following morning, those will be reviewed by the medical and nursing teams on the main ward round to determine whether there's any learning that needs to be introduced to prevent similar errors happening again. So that will take approximately 3 hours for the 2 pharmacists who are on the ward in the morning, and by 1 o'clock at lunchtime, they will then attend a multidisciplinary team meeting. So there tends to be a different meeting on each day of the week. So there could be an infectious diseases meeting that they need to attend. So that would be alongside the consultant microbiologist, the consultants who work in infectious diseases team, the critical care consultants and the pharmacists as well. They will look at any results of cultures and sensitivities to see what's growing for those particular patients and will adjust the antibiotics accordingly. They could attend a medication safety meeting where any medications errors that have been reported on the unit are discussed, and new strategies to make medicine safer will be considered. They may be at a meeting to review the infusion library on the smart pumps and to optimise the regimes that are in those for each of the drugs, depending if there have been problems or new information is available. Or they may attend the sedation ward round, which is when the pharmacist, a senior nurse and the consultant who's on duty that day will go round and review the sedation requirements of the patient in a lot more detail and maybe make a longer term plan if this is a patient who's going to be on the critical care unit for a long period of time. After that, they may then lead a training session. So this could be new doctors who've been just started on the unit. So the pharmacist will sit down with them for approximately an hour at a time, and they will go through the regular medicines that are used on the intensive care unit and how they should be prescribed. They will help them to avoid errors in terms of therapeutic drug monitoring or drugs that require adjustments due to renal or hepatic impairment, etc. They will talk them through where information is available, the guidelines that we use, etc., and just make sure that they are confident to prescribe safely at this new point in their career. And that's a really welcome session from their pharmacist for those new doctors. They may do a training session with an individual prescriber or a nurse who's been involved in a medication error. And this will be sitting down with that member of staff and talking through how the error happened and what they think could have prevented that error happening to somebody else in the future. At this point, they may work with that member of staff to develop a safety alert or some new guidance or clarify the guidance that's already available if the staff have said it's not as clear as it could be. Or they may be spend some time training a more junior member of staff who's doing a rotation in critical care and mentor and supervise them. Near the end of the afternoon, they will then undertake some medication safety work. So I've also already mentioned that we have a lot of drug shortages or drugs that stop being available, and so the pharmacists will work on providing advice on suitable alternatives. They will review guidelines. They'll maybe add IV administration information to our IV guidelines for a new drug that's become available, develop a patient safety alert, or produce a newsletter around some of the medication errors that they've picked up when they've been doing their daily review of prescriptions. So this is an example of one of the intervention newsletters that is produced on a monthly basis. So this is one for June 2022. So this information is probably too small for you to read, but there'll be information here about the harm that was associated with the errors that they've identified. This graph here shows the different types of medication errors that they've determined. So it could be the wrong dose, the wrong frequency, and not prescribed, missing information, etc. There's also information in the newsletter about the high-risk medicines that we're particularly looking at trying to prevent errors with. So we call them FIT, so it stands for potassium, heparin, insulin, and tenfold errors. So tenfold errors are where a prescriber or a nurse has administered a dose that was 10 times more or 10 times less than what was intended. And obviously that's due to a calculation error happening. So somebody may have given 300 milligrams and it should have been 30 milligrams, or a pump may have been running at 5 mils an hour and it should have been 0.5 mils an hour. So we'll look at those type of errors and look at the learning that we can identify from them, and try and introduce new procedures or training or change the pump settings to make sure they don't happen again. Within the newsletter as well, we also have this section that you can't really read that very well, but it says "you said, we did." So you told us, the staff on the intensive care unit told us that tranexamic acid was a difficult drug to prescribe and make up. There's confusion about the best concentration and it was difficult to calculate the infusion rates. So thank you to Nikki Riley and her pharmacy colleagues, so that was our team, who've updated the IV guidelines to include a new monograph to aid tranexamic acid prescribing, and the information is highlighted there that we've undertaken. This is an example of a safety alert that was produced by the pharmacy team, and this one was around the shortage of some of the IV infusion equipment and how they should best manage without those infusion equipments to make sure that drug therapy is as safe as possible. And this is another safety alert that we produced around heparin. So we used 3 different strengths of heparin, so 10 units per mil, 100 units per mil, and 1,000 units per mil. And obviously there's an opportunity to get those mixed up, and this is really just highlighting the need to think about why you're using it and therefore which is the appropriate strength. This is an example of the documentation that we use for recording the requirements for sedation and analgesia for the patient. So the pharmacists do this every day. They record what the rate is for each of the infusions and any other medication that's providing sedation and analgesia. And as the patient improves, we will then advise on the reverse of this document how they should reduce the infusion rates depending on how long the patient has been on the medication. And then we use this scoring system on the back for every 6 hours to record any symptoms of withdrawal and then provide advice on whether we should slow down the weaning or speed it up, etc., depending on the individual patient's requirements. So that's the thrust of the main overview of what the pharmacy service is. It is limited, so we only provide it 9 to 5 Monday to Friday, and then 9 till 1 on Saturdays and Sundays. We don't routinely attend the main ward round just because of the time constraints that we've got. There's loads of new medicines related guidelines required, and they obviously take longer than we would like them to, but that's again due to the limitations on the pharmacist's time. We acknowledge that we need an investment from the Trust for increased staffing requirements recommended by the NEET MPPG standards, and we're hoping to be successful with that. So just in conclusion, I wanted to refer to a document that was produced by a team in Australia who did an ethnographic study into interdisciplinary medication decision-making by pharmacists in paediatric hospitals. So what this was done in Australia, not our hospital, and it was done in general paediatric wards. But I think the conclusions that these teams came to is very much our aim for our paediatric intensive care pharmacy service at Alder Hey. So they said that paediatric pharmacists were central to complex paediatric medicines decision-making. They intervened about dosage, administration, and drug interactions. Pharmacists proactively contacted doctors and nurses about prescribing issues, and conversely, staff also then routinely approach pharmacists for medication advice. Pharmacists were perceived to be medication experts. Their extensive knowledge valued in resolving complex issues. So, for example, when off-label medicines were prescribed, when protocols were absent or ambiguous, and also where there was sometimes a tension between sticking to the protocol but then making specific change for an individual patient to make practice safer. And also where patients on multiple medications were at risk of medication errors. They identified that pharmacists have strong relationships with doctors and nurses, and because of that, the pharmacist's input and interventions were more likely to be put into practice because of the relationships that they had with doctors and nurses. So that's very much our aim at Alder Hey, and I would say if anybody was to watch what our pharmacists are doing, they would probably say we're doing the same thing. We're trying to very much be part of the multidisciplinary team to make medication use on paediatric intensive care as safe as possible. So I'd finally just like to acknowledge the Alder Hey PICU pharmacy team. So you can see there's 6 people here, even though we only have 3 employed to work on the intensive care unit. So this lady in the dark colour, this one in the blue, and this one in the white here are our 3 regular pharmacists, and the other 3 of us are more senior pharmacists who provide cover when they're not around. So we're probably not as expert as in them as the day-to-day, but we will provide to cover at weekends and holidays or when they're on holiday as well. So I hope that has been useful for you, and I'm more than happy to answer any questions you may have.